Today I will talk on knee dislocations, demographics and injuries associated with the knee dislocation. Dislocation of the knee occurs within a spectrum of injuries ranging from high energy vehicle trauma to sports injuries to low energy falls among morbidly obese patients. Mean age is 37 plus or minus 15 years, and it happens in more commonly in males, almost 60 to 70%, 30 to 40% were females. There was an equal distribution of high energy and low energy injury. Diagnosis is often straightforward with a physical examination and history taking and X-ray of the joint. MRI is generally used to confirm the multi-ligament knee injury. Measuring the patient's ankle brachial index can aid in the diagnosis of associated arterial injury, but that diagnosis may also require angiography for confirmation of the arterial repair planning. Selective arteriography based on a serial physical examination is a safe and prudent policy following a knee dislocation. There is a strong correlation between the results of a physical examination and the need for arteriography. Coming to the treatment. Treatment for a knee dislocation may require external fixation if the soft tissue envelope is compromised, or if the reduction cannot be otherwise maintained, or to assist with the protecting a vascular repair. There is a review of literature in the JBS 2009 which suggests that delayed reconstructions of a severe multiple ligament knee injuries could potentially yield equivalent outcomes in terms of stability when compared with the acute surgery. Acute surgery is highly associated with a range of motion deficits. Better to do a ligament reconstruction in the second stage or after some time. Definitive treatment. Surgical treatment often combines arthroscopic and open ligament reconstruction and can be done in a single or a two-stage procedure. Definitive treatment may also include hinged external fixation after ligament reconstruction in certain clinical situations. Hinged external fixation as a supplement to reconstruction following a knee dislocation was associated with a fewer failed ligament reconstructions compared with the external bracing. The knee is unstable after ligament reconstruction, better to put a hinged external fixation. Functional outcomes. Functional outcomes are adversely affected by concomitant vascular injuries. Patients who sustain multi-ligament knee injury with an associated popliteal artery injury requiring a bypass grafting have significantly lower knee function scores than patients without vascular involvement. Peroneal nerve injuries, the latter often results in a limited recovery of motor function and can be treated with either an arthrosis or a tendon transfer. With a multi-ligament knee dislocation and associated peroneal nerve injury, patients with a partial nerve injury are more likely to regain anti-gravity strength when compared with those with complete nerve injury, but their overall function may not improve. Conclusion. Knee dislocation is caused by high to low energy injuries. Obese patients sustain even with the low energy injuries are associated with the neurovascular deficits. Patients may need staged reconstructions of the ligaments. Functional outcomes are dependent on associated neurovascular injuries.